Good morning, everybody. Well, it's Australian morning and evening in the US.
Some areas.
In some areas, that's right. It is 11. I'll keep letting people in, but we might just start anyway. This will be recorded, and we've got a lot of information to get through. We've got some amazing presenters on our panel today. So I'm going to introduce them to you. For those of you who don't know, Dr. Lynda Dean-Duru, she's up there in the corner, so I'll introduce her first. She's a pediatric dentist from and she runs Ashburn Pediatric Dentistry in Virginia.
Ashburn Children's Dentistry,
yes. Ashburn Children's Dentistry. Yes. And Lynda and I met probably 7 years ago. We just worked out. And she's been she's one of the leaders in this early intervention space of really supporting families to get best outcomes and optimize function. So she's a wonderful resource to have here today in the dental space, an absolute leader in that thought process there. Got the fabulous Bridget Ingle, who is joining us from Europe. She is actually Australian. And once again, Bridget and I have been working closely and a fantastic support of the principles of Myo Munchee and what we're about, and an absolute font of knowledge and a great leader in this field around the thinking in lactation support and early feeding and those interventions and how they impact orofacial growth and function. So she has really helped me develop my understanding around this whole piece as well. And then for those who don't know, Cole Clayton, but anyone who's done our practitioner protocols has come across Cole Clayton, because Cole is one of the original people who help us put the protocols together. And so we've done some updating of them recently. So now he's more in the deep dive components of our education. But anytime you have a session with Cole, it is a deep dive. He doesn't do the service. He'll take you on a deep dive. And Cole and I work closely together. He's an osteopath, and we worked closely together once again 2018 around that time, and Cole was the person who did the literature review on the impacts of pacifiers that we have published on our website. And so Cole's going to talk today from that research perspective. And so we're going to jump into the conversation. And so when you have questions and things along the way, just pop them in the chat, and we'll sort of curate the conversation with some questions here that Bridget put forward, and we've just kind of carved them up to have each person talking to different areas, and then the conversations will go from there. Okay, so the first thing we're going to start with is who needs the pacifier, the parent or the baby / child, and Bridget is going to come in and start this conversation for us. Take it away, Bridget.
Thanks, Mary. Hi, everyone. This is something that I actually talk to the parents about when I either see that there's a pacifier in the little baby carrying crib, or the toddler walks in with a pacifier in the mouth. And I say to them, no judgment here, but I'm interested to know the reasons for using the pacifier, and what are the circumstances. And I say, are you in distress about the baby's situation, or is it your baby who's in distress? So the kinds of things that I see crop up in these conversations with the parents, I'm thinking, all righty, from a health professional perspective, we always just presume that it's because the baby is unsettled, they're crying. But perhaps it's how the parent can cope. What's going on in their life that may mean that maybe they are not coping in a way that they would usually cope, and be able to cope with a baby who is unsettled, or to have perceived pain, or there is something else going on in their life that they don't have the ability to be able to strategize anything. And so we look at things such as, do they think that the baby needs it, or do they know that the baby needs it? So is it that there is this impression of perceived pain, or my baby is unsettled, but I don't want to have an unsettled baby? And then I talk to them about, but what do you mean by unsettled? Because there is this set and forget kind of impression that a baby feeds and then they should lie there and look cute, or play with their toys on their change mat, which is a whole other thing. And if they're not doing that, then they're unsettled. And so I often unpack, what do you mean by unsettled, and how often is that? And can you describe the noise? Is it this that I'm hearing now? Or are we talking about that it's pain? So is it real or perceived? They're the kinds of things. We also have maybe a need for routine, either because that's a perceived thing that parents think that babies should have, or that the parents need a routine, otherwise they can't function in their day. And everyone wants to have a good baby. You know, hi, congratulations, you've had a baby. It's a good baby, good sleeper. So they like to have a baby who sleeps well. And often I see the use of pacifiers being for the babies who sleep away from the parent. So obviously we're talking about a huge age group here, the difference between a newborn or a 6-month-old or an 18-month-old. We're looking at very different sleep requirements, sleep routines, sleep perceptions by parents, etc. But I think it's important to talk about parents and safety issues, such as an unsettled baby is a risk factor for a parent, but also a baby who cries a lot in the car. That's a risk factor for a parent to be able to maintain concentration on the road for safety. So I do say, you know, that's a real thing. And we are looking after a population of babies because they've got a lot of other things going on in their life as to why they may be unsettled or appear to have pain, which is something we'll go into. And so from the baby's perspective, I think that that's a real thing, that pain and discomfort is a real thing. And we know that sucking helps that. Of the digestive system, even of their nervous system, to have that regular action, you know. So that's very true, because sucking is normal. And remember that the tongue is supposed to go up into the palate. So if the tongue can't go up into the palate, which I'm sure we're going to talk about, the baby needs some kind of replacement for it, doesn't it? And so therefore they appear to settle very well when a pacifier is put in their mouth. So therefore that's seen as being the solution, isn't it? And without us knowing perhaps the other things that are going on with the baby, the pacifier helps that. So in actual fact, you know, for babies, it's a way of posturing the jaw to hold it forward, which helps with airway. And as I said, it's that perceived tongue being into the palate, which I think for the baby is the crux for them. So they're my reasons that I was thinking of.
They're great. Thank you, Bridget. And I appreciate you jumping into that, the concepts of the why. And I think from my perspective, I'll just quickly jump in while we transition to others' perspectives too, is the timing. And I think there's great reasons there. And that's fantastic to frame that up when we're relating to parents. And I know both Cole and Lynda will have opinion on this too, how the conversations go with the parents. And it isn't about judgment. It isn't about right and wrong. It's about having a conversation, helping them understand why, because those needs change as the baby grows and gets older. So it is a really good conversation to have, so that you have had the conversation, so it doesn't come in as something, oh, why are they all of a sudden talking about that, and understanding why the parent's reliant on it, and those situations, because really the pacifier has a place as helping the baby get organised. Sometimes they're a bit disorganised and they can't quite get everything together, and that can be that, as Bridget said, the sucking's the calming and can help in lots of ways. So Lynda, I'll jump across to you there as someone who's working with the families from day dot through, and just your experiences about what Bridget's talking there and what you're finding with the families in your community.
Oh, great point. And Bridget made a lot of the points as well. And so it's the best, though, the biggest thing to understand is not to shame any parent for it. And generally, in my mind, I feel like, except unless the baby is preterm, like born before 32 weeks, the sucking reflex is something that they should already have in action. So you kind of walk back to, why is this baby dysregulated? Why does the mom feel like they have to always have something there? And part of that is that reflex has not turned on completely. And so generally we will ask questions about the birth, and even prenatally, because if the mom was a mouth breather or snoring, whatever was happening to her own biology is affecting how the baby is growing. And so when that baby comes out, birth itself is just traumatic for all of us, period, no matter how it happens. So, and I'm sure Dr. Cole will talk a little bit more about that. But understanding what that baby has been through might help you feel safer and be able to talk with that mom so that she doesn't push herself off the ledge. So if that baby, if there was intervention for a natural birth to occur, like Pitocin, or the baby was breech or C-section, it affects how that reflex will turn on. And that suck, swallow, breathe reflex, that first big cry, is what sets up their nervous system. And so if their nervous system has not been set up properly, then it's harder. Latching is a reflex. It should just come on for them. And so if they're having trouble feeding, they're probably having trouble regulating themselves as well. And our friends in the osteopathic world, which I'm very fascinated by, they call that somatic dysfunction. And I think that one of their journals says about 95% of the babies who are just even born normally, 95% of them have some compression at the back of the head. That becomes really important for us, dental providers in particular, because a lot of the important nerves come through there. There's the glossopharyngeal nerve, which regulates your breathing. There's the vagus nerve, which is your rest and digest. There's the accessory nerve that comes around that can, when they say you have torticollis, that's also to your spine. And you have the hypoglossal nerve that goes to the tongue. And so if their tongue function is diminished or their latch is diminished, then it's important to figure out, how did this baby come? Could it be that they're compressed and their nerves are not really working up to par, rather than just jumping to say, hey, it's a tongue tie and that needs to be cut? And so those are some of the things that we start to think about in our practice, and ask the moms lots of questions and send them to the appropriate places to help them turn on that function. Because again, if the nervous system doesn't have the resources, then it's hard for the brain to function. The tongue does a lot of things in our body, the regulate vision, a whole lot of things that the tongue does. So being able to make sure that you can work it back to getting to the root of it will help them so that they can quickly get off the pacifier.
Fantastic. I love the fact that you took that back to, once again, the why, what's underneath the behavior or what you're presenting that you're trying to manage. So that's fantastic to really put that in context, that's exactly right. The pacifier is serving a purpose to manage something that's expressing. Why is it expressing? So that's fantastic, Lynda. And I'm going to jump across to Cole now and say, okay, let's have a little dive there on what did you find when you looked into that research around what is showing, what is the reality of what we're seeing there, and the why of people using pacifiers, and some of those, are there any early implications in that first few months of life? Did you find anything there early that we need to be aware of, or is it a useful tool at that stage?
Well, I mean, you want me to talk about the research, but we started talking about cranial osteopathy, and I started
I know, distracted on that. Give us both.
But well, no, I mean, it's interesting because we did look at the research quite a long time ago, so it's not something I carry the detail of in the front of my mind.
Yeah, come on.
But the conclusions of it were pretty clear, and I still carry those because they're relevant to my work. But I agree with what Lynda was saying wholeheartedly in terms of birth strain and compression, and a lot of what we see. So just deflecting from the research for a second, but a lot of what we see here in a clinic that works pretty much mostly with craniodental, so osteopaths and dentists in the same room working together. And we see kids that are older. We don't see babies so much. We see them once their teeth start to be crooked, which is usually the result of these kind of strains that Lynda was talking about. So a lot of time what we see is, say a kid comes in 7, 8, 9 years old, maybe not there on the dummy, but they might have given it up about 3 or 4 and they've switched to thumb, or they've always been a thumb or a fingers. A lot of the time what that's actually trying to do is resolve cranial strain. So that let's keep it simple, that tension in the back of there. That's why I went off. I went to get the skull. But that tension through the back. But really what we're talking about is the SBS here.
Yes.
SBJ, depending on what book
You'll
you
have to describe what that is, Cole. For
I
the room.
will. So what that is if we take the mandible off,
Yeah.
this is the basisphenoid here, the back part of the sphenoid. This is the basi-occiput, front of the occiput. So that joint there is the fulcrum for the whole thing to grow. So if we're talking about teeth and jaws, you want to make sure that this is aligned, because you can work away at your teeth and even your palate, which is only a tiny part of the maxilla anyway, forever. But if this fulcrum for growth is out, you'll get relapse every time. So it remains more fluid, more cartilaginous as we add bone from behind forward, or from behind backwards, sideways. So if that joint was fused and solid, the whole thing would fall apart, it would rip apart, right, as you tried to grow. But you give up a little bit of mobility, and therefore a little bit more likelihood to develop strains. But I won't go into like the whole cranial strain thing, because that's like a whole lesson in itself. But a lot of times, let's say this, the hook to use pacifiers in this case, a lot of the times is for children, especially long term, is for babies to overcome, and young children to overcome these strains. So exactly what Lynda was referring to, they're trying to regulate their nervous system, because that's the key system to allow growth. So then we go back to this research that you're talking about, Mary, and what I did was I broke it into, okay, let's look at structure, because we know structure and function are intimate. Let's look at even biochemistry, which you think, oh, what do you really mean by that? Like, how does pacifier sucking affect things like digestion? Really interesting stuff, like later on in life, how does it affect addiction? Things like, smoking addiction and so forth, from that biochemical point. And then from the emotional viewpoint, there's actually a fair bit of stuff out there to back this up, which is really interesting. I think it's interesting, Mary, about facial mimicry. So when you've got that thing stuck in your face, right, we learn part of our psychosocial interaction and learning and social skill set comes from facial mimicry, which, as we know, if we've read Stephen Porges, that has a lot to do with vagal tone. So Lynda was talking about the vagus nerve. So we pick up unconscious cues in the face, right? So our carers will be going like, "Hi, Mary, could you give us a smile?" But if you've got a dummy stuck in your face, you can't mimic my smile, right? Because you've got this thing, and I go, "Hi, Mary," and you go like, it's the wrong reaction psychosocially. So there's structural components, there's biochemical components, and there's psychophysical components. That's the way we kind of looked at the research. And so at the end of the day, cranial strain or not, the research said, it's probably best, unless there's a couple of factors. Lynda mentioned premature babies, preemies, and also postnatal depression mums. So Bridget started to touch a little bit on that in a lighthearted way. But having been through that myself, it's not me personally, but my baby mama, we did use a pacifier for that, just simply like Bridget was saying, for emotional regulation of mum, right? And so the research was fairly clear on that. But let's say that wasn't there. 6 months is really the maximum time frame for pacifier use. Although after that you have deleterious effects, certainly on structure, But then, like I say, and like Lynda wisely said too, it's really good to have them assessed for these compressions and cranial strains, because taking that away is actually like, you've got really tight neck muscle, and you walk into the massage room and you go, actually, no, sorry, you're not coming in here today. You're going to cry, aren't you? If you really want a massage on your tight neck and someone says you can't have it, you're going to chuck a tanty. I would. So that's what it's like, taking away a dummy from one of these, or a pacifier from one of these kids that has the strain, that they're using it to counter the strain. it's a super interesting thing that we've really started to observe just clinically and put the pieces together, as well as taking trainings from the SCTF, which is the Cranial Association in America. We started to piece this together and see it, so now we can map it, so we can tell which ones really need to suck and which ones don't, basically.
Great.
Which baby's cold, do you mean?
Babies and even the kids, like
Yeah.
3, 4, 5-year-olds who have still got the pacifier or even a thumb, let's say.
Yeah.
Sometimes we go, don't worry about that. We're going to use this thing at night, but don't worry about even your OMT and all that sort of stuff. Don't worry about the pacifier cessation yet. And that was the other big piece, Mary, that came up in the literature, which just played beautifully into Myo Munchee, of course, is that the literature said, well, it's important to stop. We don't know how to stop, but cold turkey doesn't work. And so Mary and I were like, we know how to get them to stop.
Yes.
And I think that raises a great point there, Cole, about that scaffolding. And I'll get Bridget and Lynda to talk to how they work with the families. But it's scaffolding a skill set in other ways to get access to what they need. Because, you've raised a great point there. If they've never built the neurology and the ability to self-regulate in the system, then yes, you can't just take their proper way that they've been using, because they're very clever. They're working their nervous system and using that. So I think that's a great way to lead into the next discussion there, and I'll jump in with Bridget. But I'll just let people know, if they're not aware, the literature review that Cole did that and put the papers together. It was called it's called Why They Suck, and it's in our practitioner portal. And from that, we wrote what we called the safer guidelines for pacifier use. And we made recommendations about the ages and times. So all of that review that he did years ago you can read through that, it's super interesting. And as he said, he put those into different categories of impacts. And I love the mimicry. It's so interesting. It's really sad to think that you're plugging up that little human that's trying to communicate and interact, and you're putting a plug in there.
It becomes worse now because you not only got this, you got this.
Yeah, don't even go there. So I'll jump back in with Bridget now. And what does it look like in your clinic? So you've had the conversations, you've started that, and then as they start to work with you and they build different skills, what does it look like, or what do you aim to see?
Well, once I say determine the possible reason, because that's not necessarily the only reason why they're coming to me. It's a part of the picture, but that's the conversation that I'm having around the use of the pacifier. So my thing is to look at what the reasons could be, because it may not just be one reason, and what I can do to be able to help that. So I suppose for me, the big thing is that the pacifier replaces the tongue's rightful place in the palate. And that's where the tongue has to be, with the lips sealed, so the baby can nose breathe. So I'm seeing a lot of babies who are nasally congested, and everyone just thinks it's because there's snot, mucus, whatever people want to say. And so the mothers are trying to suck everything out, and sometimes there's nothing to suck out. So we're looking at lymphatic congestion. We're looking at all of the stuff that Cole was talking about, when things in behind this nose part are not put together properly. We're looking at inflammation. If the mother is breastfeeding the baby, we're perhaps looking at inflammation that's happening through something that the mother is eating or something in the environment. If the baby is formula fed on a bottle, perhaps it's the type of formula. Anything that may be causing inflammation in the nose means the baby can't breathe through the nose, so they're trying to open their mouth to mouth breathe. But when they start to suck and do that non-nutritive sucking, it clears that nasal passage. So you can keep going around and around and around in a circle. So I'm talking about how we can use it for, the shortest possible periods of time. To get back to what we're saying about premature babies, I just want to talk a little bit about jaw position, because I think the other point here is that breastfeeding is the biological norm, meaning the action of breastfeeding, that the baby uses in their mouth to hold the breast, because the breast is dynamically moving as the baby is sucking and swallowing, and babies do non-nutritive sucking at the breast as well. But remember, all of the breast tissue is very squishable. It's not something that is a permanent shape for sometimes hours of a day. There's that. And breastfeeding is blamed for the use of pacifiers. I notice it's the sucky babies, it's the breastfeeding ones. They're always the ones who want to keep sucking and using a pacifier. But Cole, did you find that that's actually not the case anyway? And I think that was simplifying it. I think it was another thing that was blamed on breastfeeding. But I think it's anything where the biological norm of what's happening in this craniofacial region, not only inside the mouth, but in cranially, when any of that is disturbed, you're getting that need for the baby to replace that. So I'm looking at those types of things, but I see a lot of babies with these jaws that are in a retracted position, and often it's said that they've got a small jaw. In my experience, I would say they don't necessarily have a small jaw, other than they are small because they're a baby compared to a child. But proportionally, it's that the jaw is not in the correct position, and when the jaw is pulled back, the tongue is pulled back. So the tongue is pulled away from the palate, the tongue goes back into the airspace. So I think they're using that non-nutritive sucking and the holding of the jaw forward in the pacifier. So I'll talk to the parent about how we can do that at rest and during feeding as our normal go-to, because we talk about the mouth being closed, but the mouth can only be closed if everything fits together and if there's nose breathing. So when the jaw is retracted back, I'll talk to the parent about how they can be posturing, just holding for a young baby, even through any baby that is held in the arms, not just a newborn, just holding and posturing the jaw forward. Pressing under here is a good little trick. You know, people are, the suction tongue activity or challenge is used quite a lot on social media, and the parents are told, look, just check for the tongue being up. However, the babies often can't do that if all of the other bits aren't in place, but the jaw has to be far enough forward so that the tongue can have any possible best impact of being able to fill the palate. And any tensions that are going down here that that we're going to be talking about later on, it also comes into play. So for me, I'm looking at how the baby is feeding, because the feeding is the active part. So I'm making sure that the baby's body position, because body support gives oral support, I'm making sure that the body position is everything, every I is dotted and every T is crossed, at getting the good body support for the shoulder girdle support, the midline stability, the bend at the hips, the feet, grounding, and the slight sniff. So when a baby doesn't have a neck in that first 3 to 4 months, they're just a head on shoulders. And I'd love Cole to talk about how that impacts at what's in behind there that parents can't see. Everyone just knows the baby's got a floppy head. Well, it's to do with their neck. And so when they're head on shoulders, they have to be in a slightly sniffing position to be able to lift that hyoid so the tongue can be as mobile as possible. And so I'm talking about that's what's happening during the activity. And then during the rest, we're trying to get this jaw forward and the tongue up to get the tongue into the palate. So simple things like that the parents can do, along with the other activities that we might give the baby of a particular age, some oral games, some mouth games, or some face massage or cheek massage, all depending on what the other issues are. So I'm trying to look at the whole picture, sitting back, even watching how the mother is holding the baby, depending on the baby's age, and saying, oh, look, can you see that the tongue has fallen down? Or I will say something such as, oh, I noticed that the baby's settled now. Is there a reason why the dummy, that we call them dummies in Australia, pacifier, is still in the baby's mouth? Oh, I don't know. It's just because that'll keep little Johnny quiet. Go, well, this is the opportunity to take it out, replace that sensation that the baby has of the palate, of the pacifier pressing up against the palate, take it out, press the tongue up instead. So I'm looking at everything that's happening in the room when the newborn baby or the slightly older baby or the toddler is in front of me. I'm looking at that whole picture.
Beautiful. And I think I just want to comment on, that was the big finding, Cole, with that literature review, was the frequency of use and the duration. And so Bridget's just touched on that. It's really encouraging parents, if they're very attached to that dummy, or you can see the child needs it, minimize the use and take it out when they've met the need, they're called pacifiers for a reason. I'm going to jump over to Lynda now for her to just talk us through what it looks like in her practice, and maybe you can talk us a little bit about the timing in your practice of how you might go about transitioning out, if you can, in an ideal world, from pacifier use.
I'm always looking to transition them from the first time I see it. I'm a recovering sleep apnea patient, and the signs were there when I was 8 months old. So I'm going crazy, like, okay, I see this, I see that. No, 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 it can't happen. However, I'm aware that I'm dealing with people and who have needs. And the biggest frustration for me is that I have not seen a pacifier in the market that goes to as far back as it needs to, which is that SBS that Cole was talking about, because that's where the stimulation goes up. And usually when I have them as babies and I'm doing like the checking their suckle, I go far back there and I touch my finger up a little to the roof of their mouth at that junction, and you just see their feet go up. And I go to the mom, okay, this is what they're looking for your breast to do. And so not all breastfeeding is equal. So some moms are just they're putting the nipples in. So thank God for Bridget and your work. You make sure that they get as much breast tissue in so they can get as far back as possible to give them that stimulation. And for me, I would like to establish nasal breathing as early as possible. So even from the time they're 2 days old, I'm looking at that. First, I work as a team. So getting to the team to get the cranial stains out. We do the baby laser, non-surgical laser to get the fascia a little bit more loose so they can have better motion. And then we go from there. Sometimes just getting the fascia loose and removing the cranial strains, they don't have to have a surgical release. And if they did have to have a surgical release, I still follow them. Part of my post-operative protocol is trying to get the neuromyofunction working as quickly as possible. And so I usually would deliver a baby munchie and just say, okay, keep their lips together over it, which the little projections on them are also stimulatory. And you're training the tongue to go up even more quickly so that they don't if they're going to get addicted to something, let it be something that can help. Again, like I said, the pacifier, in my view, I have not seen one yet that the shape or the length of it is, in my mind, doing anatomical for that baby as much as possible. And as they get older, obviously we start incorporating the chewing and things like that, making sure there's activity, keep them busy, keep them occupied. And as they get older, well, usually 6 months of age, we're saying that's got to come out. And you're gently doing more. You can still give them hard foods to chew. You got to have them with the lost art of chewing and how important it is and how it helps that jaw, which most times they're born with the jaw a little right fanatic to help them come through the canal. But again, if they have the good reflexes, then it slowly starts coming forward. But as they start chewing, it gets that temporal bone to move more so that that bottom jaw can start coming forward. The TMJ is starting to grow better. And so there's just a lot of reasons to get them into those and just try to get away from the pacifier. But again, it's a case by case. If a family is going through turmoil, you'll know to support them. You give them the education, what it needs to be, and then gently support them on how to get the baby off of it as well.
Yes, I think I love that. And it's in an ideal world, what we're looking for is that there's not a use by date on the actual pacifier, but it's actually on the child. When the child gets to that 6-month age, when they've got a lot of other faculties and they should have all their movement, integration, stability, the brain is ready for the chewing and the feeding and all the jaw growth that's required for managing the solids and the drink and the communication. That's what we need. That trigeminal system has to get really activated. And if you keep them in that suck response as a primary, it really inhibits how that next program's trying to load. And I think so it just needs to be a nice, easy, natural conversation with people that, oh, did you know that sucking is the that's that age appropriate. That's how that brain's wiring up in that first part of life. But it really should be bringing it back, and the chewing is upregulated, and it's a very different set of muscles, neurology, joints, all of it that's required for that. So it's yeah, it's not about shaming or anything. And if people are really attached to it for different reasons, I've definitely seen over time in my own clinical practice bringing in a munchie at the same time. Don't ever feel like, oh, they won't get rid of that, I won't bother bringing in that. Bring it in anyway, because it's a beneficial habit which will help the brain get the information it needs to help scaffold out. And Cole talked about that with older kids, but definitely just starting to, it's a useful educational tool as well, the BB, to try and educate to parents. Here's a tool, have it in the pram or the car seat, so they put it in instead of automatically giving them the pacifier. Because that's what I notice is kids who are happy, they're out and about, and they've got one of these in there. And it's totally, and the other thing is, and who touched on it before, Lynda, I think, about the eyes. The eyes and the tongue and the central system is trying to really get everything working, and that you're putting in this massive inhibition to the brain, trying to get all the right information to get that set up. When you see a 2-year-old walking around with a dummy in its mouth, that's a problem. That's a big problem. Okay, I might jump over there to Cole, who did already allude to that idea of those kids who need the sucking and the kids who don't, and just share a little bit more around that, so that people who are working in that age group a bit older can sort of see what you're talking about there.
I think you said it well, Mary. Like, just listening to people talk as well in the last little bit there, it's a massive inhibition. I think that's like really eloquent way of describing pacifiers typically. Because even if they do, just musing, even if they do come, they're doing it for a structural reason to offset a cranial strain, it's not really changing or helping anything. It's literally pacifying it, right? So it's allowing them to function, but it is an inhibition to their continued growth and development, like what you were talking about. So I guess like my reflection is that certainly newborn babies are meant to be a little bit retrognathic in the jaw because of what Bridget said. We don't have developed neck muscles, particularly the SCM, the sternocleidomastoid. And so head control and movement, as you know, sucking, swallowing, breathing, but particularly movement as well. So like, I know we talk about this a lot, but the car seats that Bridget mentioned before, which you just unclip and you keep the kid in it and you carry them around, you swing it, they're not moving anywhere. You know, that they go from that to the bouncer seat and sitting and watching you do stuff. They're missing so much of this like neural pruning and vital information, you know, even just being carried, picked up, put down, you know, moved around, rocked, bounced, all that sort of stuff. Vital information that's going into the brain to trigger and these intrinsic and then extrinsic muscles of the neck to grow. So if you think about then the pacifier being in there too, it's again an inhibition to it, isn't it? It's because it's the tongue should be moving and dynamic. It should be moving in and out. You know, we don't want babies. Yeah, we don't want babies just sitting there with their tongues like completely static. The tongue should be, it's sensing. It's part of that whole neural circuit, like you said, Mary, eyes and tongue to bring back in information and to have the interaction for chewing between the sensory and the motor, right? And what you were talking about the trigeminal nuclei. So yeah, it's super interesting. And I wonder, like, do you see a lot of trouble with babies transitioning from like into solids? Maybe Bridget sees this too, into solids, who have had that frequency, high frequency and long duration of pacifier use. Do you find that they have a lot of difficulty actually learning to chew and to swallow properly?
Absolutely.
Talk to that, Bridget or Lynda. Yeah.
Yeah, we find quite a lot of that. Well, I used to do a lot more in my practice before I started following them, even after they've had a release or not, if they had any trouble latching or they've had what I suspect to be like those cranial strains, it sort of monitor them more closely. And for a lot of the ones that we've been monitoring and getting, it's a lot less now. But yeah, in the past, actually a third of my practice were people who had releases elsewhere. They're coming at 6, 9 months of age. They're not sleeping well. They're choking on solids. And you just have to get back to the basics, get their nervous system online. And it's easier for them to get off the pacifier. They have what they need inside of them. So they're not looking for a pacifier. So sometimes you have to like get the parents to understand that and be able to let go, because now the baby is sleeping better, they're eating better, so there's no need for that. So that is true.
And
My
I think
comment-
that you go, Bridget, you go.
Sorry, my comment about that is that the pacifiers sitting there, it's keeping it forward back, kind of a tongue thrust, rather than this more other dynamic situation happening in the mouth, as Cole was saying. But remember that not all pacifiers are made equal, because not all mouths are made equal. And when you're looking at a mouth, you're looking at the roof being the palate. What is the shape and the width and the length of that palate for size of the baby's head of their age, but also maybe it doesn't fit their head correctly. And the floor is the tongue, and it's supposed to expand that way and go this way and cup around it, etc., etc. So I've got some little demos here. I just want to say, there's a huge difference between having something that's like that large. Oh, you can't see, it's enormous on my hand, compared to something that is more flat, that occupies less space. Or then there's one that's more long. And I'm not giving an advertisement for anything. I'm just saying that we also need to be looking at the shape and the size of what the baby is put in their mouth. And why are they choosing a particular shape? Is it a brand? Is it a social media thing? Is it the only one that the baby will hold in their mouth? So what's that telling us about it? If the baby can only hold one that is very bulby and round, is that because that's what the palate shape is? And so that's the only one that fits up in there. So it becomes a self-fulfilling prophecy. You can start off with a reasonably good shaped palate and a pacifier that's used for a baby being unsettled because of food intolerance, say, let's say that, or birth strain. And that palate is going to become poorly shaped as a result of using the pacifier, as is the whole of the maxilla and the jaw, which we're going to talk about. So which has come first? Is it because the baby is born with a palate that is suboptimal, as in the higher it is and the more narrow it is? We know that there's all of those other things, but that's happening at birth. But that's been like that in utero. So we know that that sucking pattern, and then the strains that were happening in utero, and the stress and the lack of oxygen, which Lynda alluded to, from sleep disordered breathing and sleep apnea in women, has impacted that craniofacial growth. So you have a baby who's born with a palate that already may be suboptimal. They've for sure got some other strains happening down here. And so we're talking about a very different thing. So if the longer that a baby has had that in that period of time prior to starting solid food, and remembering they're starting off with a bit of taste and compaction, and then they're going to learn to shuffle it sideways, and then they're going to learn to move it from side to side. They can't do that as effectively when the tongue has been held down and being restricted in dynamic movement, but also the ceiling. So you have this space here that the baby doesn't know what to do with, because things don't fit together when the dummy's not in there, but the pacifier has been part of the creation and the ongoing self-fulfilling prophecy of using the pacifier. And so that the tongue doesn't seem to fire as well to be able to find where that piece of food is, to be able to move it or to squish it or create the bolus. And if it does, it's getting lost up because it's up there and it's going, oh no, that's going to be way too hard for me to do that. I won't be able to do that.
That's great information, Bridget, and I really love the way you're articulating, describing that, because that's the first area of brain mapping that the baby's going to get this 3D intraoral space, And that's exactly what happens. Yes, there's a whole, you know, and all of us will have had those children where they've got no awareness of that top part of the palate. And that's where you go and see a tongue tie released into a situation where they've got no spatial awareness inside that space. And I think that you just articulated that so beautifully, that that dummy's taking up a lot of that space. So it's creating connection to it when it should actually be the tongue up there creating that. So yes, and the longer that's left in there, the more dysfunctional it becomes. But we'll jump over now, and I'm going to get Cole and Lynda from that, because they're both working in those dental spaces, both working. So Lynda's dentist working with an osteopath, and Cole is an osteopath working with a dentist. So they're both with those wonderful holistic collaborative teams, which we know is the game changer. And I know Bridget does that with all of her patients as well. She's working with others in the community, and that's why it's so important. Everyone has to have your collaborative team, because to get these outcomes. But let's talk, Lynda, about who they are and what they look like in your practice down the track a little bit. Who are they when they come in, and what do you see? What are the outcomes?
So if we didn't get them to develop how we would like them to, they come in, first of all, their mouth is open. And you see the dark circles under their eyes. And when you actually look at their dentition, most of the time you're going to see an open bite, which means that the back teeth touch, but the front teeth don't touch. And a lot of times you also see a cross bite, which means the top jaw is inside of the bottom jaw. And sometimes you might even see a deep bite, which I'm surprised on how that happens, but again, not so much. And when you do have a deep bite, there's a lot more issues going on. If you actually have them open their mouth too closely to where it should be like a normal overbite overjet, and look, you'll see that the top jaw is narrower than the bottom jaw. So they actually have a crossbite. There's a crossbite in disguise in my mind. And those are some of what we see. And they tend to get a lot more cavities on their mouths, quite a bit. And part of it is from that breathing through their mouth. And occasionally some parents add like honey or syrup or sugars or ice cream to the pacifiers. I don't know why, but occasionally we get that. But anyway,
Can I ask, are you seeing a strong correlation then with things like sleep disturbance, behavioural? Are you seeing some of that turn up in the same package as?
Oh yes, they generally come together. Most times they're tossing and turning at night, and for a lot of them, they've kept a lot of their reflexes, their primitive reflexes are not integrated. And usually by the time they're 6 months old and those front teeth come in, that's where you start to get the anterior coupling reflex, which now starts to tell the tongue, you got to go back and you got to start going this way and not this way. And then the back teeth come in, that's your posture, that's your upright when you're now starting to walk. So, and a lot of them, because a lot of those primitive reflexes have not integrated, they're having a lot of sleep issues, tantrums, there's some of them are just still bedwetting even after they should have been potty trained. Sometimes you have the problem with handwriting and things like, or they can't read, they can't track. So there's so many things that are connected with in the craniofacial area has now formed properly. And a lot of parents don't know, and especially that a dentist will be able to help them connect those dots. But it's not what we learn in school. Obviously, that's extra training and interest training, continuous education, and working with other members of the healthcare field. You guys, the osteopath, and those, so you start to learn more, and then you help to direct the parents. For me, it eventually boils down to the nervous system, because if the brain doesn't have the resources, all bets are off. Correct me if I'm wrong, Cole.
And I'll just quickly touch in on that, because I think that's probably the biggest thing I'm seeing now, is that I think pacifiers are interfering with primitive reflex integration. I think they're actually not allowing the system to get that brainstem fully online, and that it's probably an indicator, if they're staying on it, that they haven't fully neurologically gotten their developmental milestones happening, because really they should have that all in place by 6 months. They should, all those reflexes should be, all those basic ones that they were born with should be very much coming in and under control. And I do look at that as a bit of a holding pattern of interfering with that. And so then there's other factors there too around cranial compressions and upper cervical compromise and things that are part of that. But I do think we do need to look at that, and those of us who need to, really work with someone who understands the neurology. So thank you, Lynda, for jumping onto that. Cole, over to you.
I don't reckon you have to think that it's preventing integration of primitive reflexes. I think it's a given.
Yeah.
I just like, we'll do something a little practical, because this is worth, I think, with just a little bit of careful observation, pretty much everyone here should be able to pick this. So there's 9 basic cranial strains, right? And so because that SBS is the fulcrum for growth, it's not that growth happens from there, it just allows it to happen, but it has to remain mobile, like I said. So we give up a little bit of it, maybe going this way or this way or this way, and that can create a lot of those bite presentations later on that we see. And the one I wanted to talk about is actually what we call going vertically, so a vertical strain, because it relates to the use of the pacifier. So if you can identify this in a baby, in a toddler, even in an older child, you'll understand why they don't want to lose a pacifier or a thumb. So we named the strain from the position of the sphenoid, this yellow bone here, right? So in an inferior vertical strain, I'll see if I can do it, but basically, there we go. That sphenoid drops down. Can you see it down a little bit, hopefully, on the thing? And what will happen there is that frontal bone will go with it to some degree. So that coronal suture, which you can easily identify and feel in babies, toddlers, even kids who have this problem, you can feel a little ridge there, and you'll feel that the frontal bones drop down. Okay, so we can have, that's an inferior vertical strain. You can have a superior, which is the opposite, and the frontal will come up. So you have to kind of have a look at their head and go, is that frontal sticking up like a dolphin or kind of dropping down? And what the reason that's important is if that sphenoid drops inferior, the sphenoid will go into what we call extension. So it'll go essentially backwards. And what that'll do is our favorite bone everyone loves, the maxilla, will actually flare forwards. So you'll create something, the premaxilla will flare forwards. You'll create something of what we might call a class 2 malocclusion. So the teeth will kind of go forwards and be narrow at the front from an inferior vertical. So if you have an inferior vertical where this has dropped down, what might you want to do to push it back up? That's where a non-nutritive suck will come in. So that's just an example of how these things play out clinically. So you might have a 6 or 7 year old who comes in with all that autonomic dysregulation. They don't sleep. They don't do this. They don't do that. The best one we've ever had is, I think it was the opposite of superior, but he would bang his head against the pillow at night pretty hard for a repeated time. And that was his way of self-soothing. And the mum's like, why is this relaxing to him? I was like, because he's being an osteopath here. But this inferior vertical strain, and you can sort of see it if you look at the head side on, and you kind of see that the frontal's kind of sloping down and away. You can probably have and the teeth, if they've come in, they've started to flare forwards, and the premax is narrow, and maybe even the palate's relatively high and narrow, like Bridge was talking about. Sometimes they can be the ones that will really actually relying on that dummy or thumb to be there. So I just thought I'd share that because it's something we see, and we correct. We're talking about alpha appliances and stuff. We correct with cranial osteopathy and using the alpha appliance to hold that. But we definitely don't. So we had one the other day. He was a classic, and his dad, he's 9 and he's still sucking his thumb. But after 1 month of ALF, he's still sucking his thumb. but I wasn't on him about that. But what he has stopped doing is falling asleep in the car. What he has stopped doing is this. You know, he's got lip seal and stuff just by creating a little bit of stimulus through the skull to start to change this. So at this point, I'm like, there's the mum's like, and he's still sucking his thumb, and I was like, hey, come on. But I didn't want to hammer him because I know that it's actually his way of placating his birth strain that he's had for the last 9 years. So it's super interesting when you.
You go. And I was just going to say, and I think that's, it's probably people in the room going, oh, it's so hard to fix. No, it's too complex. And how do I work with this? Prevention is the solution. That's what we're really trying to do, is to try and prevent as many of these as we can, because they, you know, what you guys are doing, and it does take that big team, because you need that nuance of understanding. And I think Cole just showed it really well articulated, how that cranial system is creating a malocclusion, what it looks like. The teeth are what gets seen and what get addressed. But let's understand that it all started with dysfunctional patterns somewhere along the line. And if we can help parents make different choices earlier, we've got a way better chance of needing less interventions. We're not going to need none, but there's certain inputs they do need, and the pacifier is really impacting those inputs. Let me just see what else we want to cover here today, because we've got 4 more minutes, and we might have questions. No questions so far. Oh, Bridget's got some rules for baby pacifier use.
I do. I've got rules about lots of things, actually. I call them suggestions or best management protocols, or homework they can do. It's got lots of other names, doesn't it? But I suppose the thing is, in this particular situation, to try and help the parent be aware of their own habits of automatically getting it out of their pocket and putting it in. I'm about to hop in the car, so I'm automatically going to put it in the mouth, or the baby's about to go to sleep, I'll put it in the mouth. So for them to identify those kinds of situations. So if the baby is happy, don't use it. Don't use it automatically. And if it is determined that the parent or the baby needs it at that particular point of time, the thing is, you're going to be choosing one that is the least occupying space in the mouth as possible. So they may have to change the shape that they're using, and putting it in for the shortest period of time. And then as soon as the situation has passed, the crying or the trip in the car or the whatever it is, as soon as it is passed, to remove it, and then to press the tongue up from there, which often means posturing the jaw forward a little bit as well, and then closing the lips. If the situation is that the nose is congested, make sure that the original reason for using the pacifier is gradually attended to over the period of time. So they're my rules. And I say to the parent, don't offer it, but don't refuse it either, meaning that it is one tool that may be needed for a particular period of time. And we all recognize that for some babies or parents, that is more important at a particular time in the day, moment in the day, or moment in the life, but not for it to be an automatic thing. And being very careful of grandparents, quite frankly. I often talk about, only the parents can be the ones who are in charge of the pacifier, and the grandparents don't get to be in charge of the pacifier, because grandparents want to be able to hold the babies for longer, play with them for longer, and everyone's more likely to let that happen if the baby is happy. As soon as the baby starts to look unsettled or can't go to sleep, then the baby may be taken away from the grandparent. Oh, playtime's over now, or cuddle time hasn't worked, grandma, so we'll take the baby. So being careful of that, because a grandparent can tend to leave it in for way longer, because they want to have that quiet baby that they can hold for longer before it is taken away. So yeah, they're Bridget's rules.
Right.
Oh, and replacing it with the chewing, replacing it with a proper chew toy, or the end of the munchie, or age appropriate, then it gets turned around for them to be that way. And it's always that replacement thing. You can't just take away their prop without giving them the support. So all of the stuff that the osteopaths and chiropractors are doing, the things that we're doing with the orofacial stimulation with massage or exercises are all the support things that are happening around the whole situation. So you can't just pull away all of the scaffolding and expect the baby to be able to sort out their life.
Yeah, and I think just helping the parents understand that they will build new skills and they will get to a point where they will be able to, yes. And I think there are different species, as in brand new babies are very different to 6-month-old babies, and you need to build those skills.
Exactly.
Now, there's a couple of questions up, and they're both targeted at you, Cole. We're going to have to bring you on for the first one. It says, we need a much longer lecture from Cole to explain more about the 9 basic cranial inferior back vertical strain stuff that we dental people don't understand. So yes, we can organise that, Erica. I'll chat with Cole.
I'm in February, Dr. Erica.
Oh, there you go.
We run a 2-day course on that. Not just that, but it's definitely in it. So if you want to head down to Sydney,
come on down, Erica. Come on down.
But I mean, we can do a lecture on that, Mary. But I'd have to wait for the invitation, Dr. Erica.
Oh well, I can. I can always send you another one. That's good.
And
working out what's on next
in
year.
terms of the selection criteria, so it's actually, Melanie, it's based on the strain. So I'm actually in our assessment room here. So every kid comes and plays on that play mat first, and then we take them over to that assessment table. And all our dentists, actually, Erica, all our dentists are trained in cranial osteopathy as well. So our dentists are able to put their hands on their head and feel the strains too. So it's definitely doable. And that's how we determine it, because if it isn't say that one I described, an inferior, then we probably wouldn't take the dummy off them, or their suck wouldn't just not ask them to suck. Same for a compression strain, but if it was a superior, for example, be making it worse, so we would definitely want to take that away from the get-go. So we'd use Munchees, myofunctional, that sort of stuff to help with the habit cessation, as well as the dental appliances, and the cranial work as well, because you can't just, in my opinion, you can't just shove a dental appliance or even a Munchee, as good as it all is, because the body has to have the capacity to overcome these strains, and it doesn't always have that. So sometimes, more often than not, in the kids we see, we need treatment as well. So we start to get these cranial bones, or greasing up the sutures and get them moving a little bit better, and then hold that treatment and that motion with dental appliances. That's the key, because the mouth's so important with how it can transmute forces to the rest of the skull. So that's why a lot of ortho stuff's up, because it's that principle inverted. So me being me, Mary, I tend to do things back to front and backwards. So I take that paradigm and then turn it the other way and go, well, we can use the mouth to influence the head, rather than the head influencing the mouth and stuffing up the teeth.
And I'm going to jump across to Lynda now, because I'm sure she has the same view of the world from the dental perspective. Let's just 20 cents worth from you on anything Cole just talked about there.
Oh, no, I suppose if you're doing orthodontics, you should get some training in dental, in osteopathy, because again, that's part of how nature actually made it to be. So you want to be able to do that so your results are stable. I'm a big fan of the neurology part, the nervous system, getting the brain to get electricity and have resources to be able to help a lot of the patients do what they already have inside of them to do. And I think is Louis Laney, who always says, you need a double D battery and you just have a AAA battery. That's not gonna work, So it makes sense, because we're asking the brain to do so much with so little. There's so many tabs open. It's like on our computer, and this tab, that tab, the kids are always almost in a high sympathetic overdrive. And just like Cole said, they're not ready to receive an appliance sometimes. So it's best to work at that first, get them desensitized, get a little bit more calm, and that way your dental treatment will go a lot easier. and work better as well. Dentists were trained just to look for, oh, let's do quick, get some space. That's not what the body wants. So if you ever have a chance to mix cornstarch with water and just push on it hard, you can feel like it doesn't go anywhere. But if you just gently put your finger on it, it almost flows. And that's how your body wants to grow. At least the way that I see it, in my little opinion and my knowledge. And that's always gentle. Gentler is better. So if any of the dentists here, if you get a chance, study some, go learn some osteopathy or work with somebody who has the knowledge, your work will be so much easier for you.
Brilliant.
Yeah,
Oh, well, I've loved having you all on.
I would just say to that the Sutherland Cranial Teaching Foundation, the SCTF, are more than happy to train dentists. So if you're in the States, look up the SCTF course. All our dentists here, it's changed their lives, changed my life, and I was already into it. So it's a well worth doing that course.
Yeah,
Like,
it's very
up what
exciting.
Lynn said, a dentist who can palpate the cranium is a superpower.
Yeah, wonderful. No, that's amazing, because I think, and it's so exciting as practitioners to be able to go into a different sphere, and you're not going to become an osteopath, but for your understanding, it's phenomenal. It's the same as us going in all the dental spaces and myofunctional and different things where we learn so much, and then we go back to our primary practitioner. Can't speak, sorry, what type of practitioner we are. And we're informed, we think differently, just informs our thinking, which we love. So thank you all, phenomenal panel of amazing experts in their fields. Cole Clayton from the Quantum Kid, if you're not following those, get on and follow them. The fabulous Bridget Ingle, who is part of the COMT, the Centre for Orofacial Myofunctional Therapy with Sri Wheaton, and they educate in Australia. They do amazing programs as well. Breathe, Feed, Eat, Sleep, is that right?
Right, Mary, thanks.
Got it. And Lynda Dean-Duru, who is now lecturing. She's on the lecture circuit in the US, and she's changing the way airway dentists are doing airway dentistry, which is very exciting. She's bringing that big model to the table, which is so exciting. And thank you, Lynda from Ashburn Pediatric Dentistry. All right, great to have you all here. And I'll bring some exciting speakers on again next year. But there's probably one more next month, November. And thanks again. Bye.